Good afternoon. Good afternoon, everyone. pCoE KSCH New Delhi welcomes all the participants for today's RDLS session. Today's topic is prophylaxis for OIs in children, and the speaker is Dr. Harshita Gosainwal. Dr. Harshita ma'am is currently working as a medical officer with the ARD Center at Kalavati Saran Children's Hospital, that is KSCH, New Delhi. We welcome you, ma'am, for today's session and request you to start the session.
Thank you, Shweta, for the introduction. Good afternoon, everybody. Am I audible?
Yes, ma'am.
Okay. So today's title is Prophylaxis for Opportunistic Infections in Children. I'll be talking about the opportunistic infection the children have and how to deal them and how can we prevent them. So, as globally, there are so many opportunistic infections that are the leading cause of mortality and morbidity among the CLHIV. Contributes to more than 90% of HIV related deaths. So the CLHIV are susceptible to infection with with multitude of opportunistic organisms, including protozoa, fungi, viruses, and bacteria. CLHIV have an immature immune system, which is coupled with a lack of prior exposure to these organisms in CLHIV, further increase the susceptibility or the risk for these infections. In contrast to HIV infected adults or PLHIV, you can say correlation between the CD4 cell status and the opportunistic infection is poor in CLHIV. The treatment and the prevention of OI is an important component uh, of comprehensive care of CLHIV. The prevention of common childhood infections other than opportunistic infection, which can be life-threatening in CLHIV, is an additional challenge. Since opportunistic infections or the events tend to recur, prophylaxis need to be continually given regardless of any previous successful treatment. So that is the important line that if any opportunistic events which are reoccurring, we need to give prophylaxis to maintain that the patient does not have that opportunistic infection again and again. So now from the graph, you can see the CD4 count and the common opportunistic infections. So in the CD4 count, you can see if a patient have a thousand CD4 count, let's say, patient does not have any opportunistic infections from the over it, you can see. As the CD4 count is decreasing from like 1,000 to 700 to 500, there are many opportunistic infections the patient can have. Patient can have a chronic demyelinating injury, idiopathic thrombocytopenia, Rett syndrome, and everybody knows that tuberculosis is very common opportunistic infection in CLHIV or PLHIV. And from that, you can see if the patient have a CD4 count less than 200, it can have a Kaposi sarcoma, cryptococcosis, or PCV infection, MAC, and cytomegalovirus infection. So in this, there is a correlation between the occurrence of opportunistic infection and CD4 count. From the graph, as you can see, as the CD4 count is decreasing, there are some life-threatening OIs. From that, you can see the patient can have cryptococcal meningitis, the CMV infection. CMV infection can lead to the blindness, and eventually the patient can deteriorate. And that make the management of HIV difficult. Therefore, early identification of symptoms and adherence to appropriate treatment are extremely important. So, since opportunistic events tend to recur, sometimes prophylaxis or preventive therapy needs to be given continuously, given even after previous successful treatment until the patient achieves immune restoration. So, the prophylaxis or the preventive therapy for preventable opportunistic infection is given in the table. So, there are two types of prevention as we have started. One is primary prevention and other is secondary infection. Primary prophylaxis is given before the appearance of any opportunistic infection. It is called as primary prophylaxis. Secondary prophylaxis is prophylaxis given after the successful completion of a treatment of opportunistic infection. It is called as secondary prophylaxis. From the table, you can see the primary prevention or the prophylaxis prevent PCP. The previous PCP infection is cotrimoxazole or the Septran therapy, you can say. To prevent tuberculosis, it is isoniazid, and to prevent the cryptococcal infection, it is fluconazole. And for the secondary infection or secondary prophylaxis, to prevent the recurrence of PCP, again we give cotrimoxazole or Septran therapy. And to prevent recurrence of TB, again we give isoniazid therapy. And to prevent the recurrence of cryptococcal infection, we again give fluconazole. So the co-tranmoxazole prophylaxis therapy, as we say CPT or the septum therapy, it is a very effective and a proven strategy for reducing mortality and morbidity in CLHIV. Does not only protect the infant and the children from PCP infection, but also from malaria, diarrhea due to isospora, cyclospora, toxoplasmosis, and other bacterial infection. One more important thing is all the HIV exposed infant should get co-trimoxazole therapy prophylaxis from the age of 6 weeks until HIV is reliably excluded or the HIV status is negative. In all those confirmed to be HIV infected, CPD should continue till 5 years of age, irrespective of the CD4 count. The recommended dose of CPT is 5 mg per kg per day of trimethoprim as a single dose daily. So the main important point is all the HIV exposed infants should get CPT therapy, the septum therapy, in the age of 6 years, 6 weeks, sorry, until HIV is reliably excluded. And all those who have confirmed HIV infected, CPT should be continued till 5 years of age. And from the graph, you can see for whom all when to start the septum therapy and when to discontinue the CPT prophylaxis. For all the HIV exposed infant and children, as we have said, from the 6 weeks of age, we have to give them CPT or septum therapy or at the first encounter whenever the patient comes. When to discontinue? We have to discontinue when the HIV infection has been reliably excluded by a negative antibody test at 18 months or 20 months, regardless of ARV initiation. All the HIV infants and the children up to 5 years of age is given CPD therapy regardless of WHO stage or CD4 count or percentage. At 5 years of age, when the clinical or immunological indicators confirm restoration of the immune system for more than 6 months, that is, child more than 5 years of age, who is having WHO clinical staging 1 or 2, and the CD4 count is more than 350 cells on two occasions, not less than 6 months apart. All the HIV infected children for more than 5 years of age. When to start the CPT therapy? When there is a clinical stage 3, like in the pulmonary tuberculosis, stage 4 extrapulmonary tuberculosis, or you can see CMV infection or a PCP infection of CD4. We need to start in the stage 3 and stage 4 of WHO clinical staging, regardless of the CD4 count or the percentage. And when to discontinue the CPT prophylaxis? When there is a clinical or immunological indicator which confirms that the status of the patient is restored and that the testing should be done for more than 6 months apart. That is a child more than 5 years of age with a WHO clinical staging 1 and 2 and the CD4 count more than 350 on the two occasions, not less than 6 months apart. And when to give as a secondary prophylaxis after the completion of treatment for PCP. And when do we stop? If the child is less than 5 years, we continue the septum therapy. If the child is more than 5 years, then when this child's WHO clinical staging becomes 1 or 2, and the CD4 counts more than 350, and both the things should be on two occasions, not less than 6 months apart. So the timing of starting of CPD in relation to initiating ART. We don't have to wait for ART initiation if we know the CD4 count of the patient is less than 350. We start the CPT therapy prophylaxis first. Start ART after starting the septum therapy or as soon as the CPT is tolerated and the patient has completed the preparedness phase of the counseling. So this is the chart you can see. This is the table. For all the HIV exposed infant and children, we start the CPT at the 6 weeks of age or whenever the patient comes to you. And if the early infant diagnosis at 6 weeks onward, if the EID is negative, we continue the CPT till HIV infection has been reliably excluded by a negative antibody test at 18 months or 20 months. And patient becomes EID positive, to continue the CPT till 5 years of age, regardless of the WHO staging or the CD4 count or CD4 percentage. Like I said, after 5 years of age, you continue or start if the CD4 counts become less than 350 or WHO clinical staging becomes 3 or 4. Same case goes for the HIV diagnosed children who are after 5 years of age to continue or start if the CD4 count is less than 350 and the WHO clinic or the WHO clinical staging is 3 and 4. When do we stop this therapy, CPT therapy? When the CD4 counts become more than 350 and at least two occasions done 6 months apart. What are the contraindication of the Sepran therapy? It should not be initiated on CPT or stop. Children with a history of severe adverse reaction, grade 4 reaction to Septran or the other sulfa drugs, children with G6PD deficiency. Alternative drug in this case is Dapsone. The dose is 2 mg per kg once daily and it should not exceed more than 100 mg per day orally. So if a patient is allergic or there is a drug reaction from the Septran therapy, we have to do desensitization. How is it done? The 4-trimoxazole desensitization has been shown to successfully and save in approximately 70% of the patient with previous mild to moderate hypersensitivity. If the patient reports a history of hypersensitivity or a drug allergy to sulfa drug containing drugs, regime is followed, which should be attempted only in a hospital setting. Desensitization should not be attempted in individuals with a history of severe cotrimoxazole or other sulfonamide reaction. Desensitization can be attempted 2 weeks after a non-severe grade 3 or less cotrimoxazole reaction, which has resulted in a temporary interruption in CPT. If any reaction occurs, the desensitization regime should be stopped. Once the patient recovers fully, a dapsone at a dosage of 2 mg per kg and which should not exceed 100 mg per day shall be tried. Some patient may be allergic to both, can be allergic to Septran and the dapsone therapy. So this is protocol for Septran or a cotrimoxazole desensitization in adults and children. In the day one, you can see we can give 8 mg of sulfamethoxazole with 16 mg of trimethoprim in 2 ml oral solution. Further up, you can see the day 2, we are increasing the dose. Day 3, we are increasing the dose. And day 6, we're giving a full double strength tablet, Ceptan tablet. And this is the weight band. This is in your guidelines, and you must be having this. According to weight and age based dosing for CPT therapy. Like for the less than 5 years of age, how 2.5 ml syrup is given. And if the child is weighing more than weighing around 5 to 10 months, the syrup you can give 5 ml syrup to them. And according to the weight band, you need to give the syrup or a tablet for the child. And the dosage is 5 mg per kg of trimethoprim per day orally once daily. And it should be emphasized to patients and families that the cotrimoxazole does not treat and cure HIV infection. It is just for prophylaxis for opportunistic infection a child can have or child was having before. Counsel the caregivers well for the side effect of CPD. Just like you can say there are drug reactions with this. And discontinue CPD, the Septran therapy, if there is Steven-Johnson syndrome, if there are severe liver disease, the LFTs are deranged, severe anemia, severe pancytopenia, or the completely excluded HIV infection. Splitting the tablets and the quarter is not recommended unless there is no syrup available. But now in the program, we have the syrup and the double strength tablet and a single strength tablet available in the program. Now the INH preventive therapy or the TB preventive therapy, you can say. Isoniazid preventive therapy. Isoniazid preventive therapy entails the administration of isoniazid drug, which is anti-tubercular drug, to individuals with latent TB infection, so as to prevent progression to active TB. So we give IPT so that the latent TB infection which a patient must be having or a CLHIV must be having does not progress into the active TB disease. Isoniazid is one of the most effective bactericidal anti-TB drugs that protect against progression of latent TB infection into active disease. And it also prevents TB reinfection post-exposure to an open case of TB. The effects of IPT augment the effectiveness of ART in reducing the incidence of TB. Concomitant administration of both ART and IPT, there is a likelihood of restoration of TB-specific immunity by ART, and the beneficially effect of IPD is likely to be prolonged. IPD does not promote isoniazid resistance when used to treat latent TB infection. So latent TB infection, the Mycobacterium tuberculosis bacilli are very few in number and are dividing slowly, resulting in extremely low risk of selecting drug-resistant mutants. So, who are eligible for IPT? All the children living with HIV who are within 1 year of age. The four is screening negative, who do not report the current cough, any fever, poor weight gain, weight loss, a history of contact with a TB case, are unlikely to be having an active TB. Children with no contradiction are listed in the next slide. IPD is not an emergency intervention. If there is any doubt about the TB status of a patient, IPD should be delayed. This is a very important point that IPD is not an emergency intervention. So, if you are having any doubt about TB status, like you feel like there is a cough or a fever or a poor weight gain or any forest positive signs, you can delay the IPT and then you can work up the patient for TB. So children living with HIV who are more than 12 months of age, who do not report current cough, fever, poor weight gain, and history of contact with TB cases, are unlikely to have active TB. Additional investigation. These are additional investigations, not mandatory. That is a chest X-ray or a tuberculin skin test that you call Montos test can help in ruling out active TB, but these are not mandatory tests. So what are the contraindications to IPT? If there is an active TB disease, there are active hepatitis, or the LFTs are deranged. Signs and symptoms of peripheral neuropathy, such as persistent tingling, numbness, and burning sensation in the limbs, regular and heavy alcohol consumption, and the symptoms of peripheral neuropathy. Concurrent use of any other hepatotoxic medications, contact with any MDR, the multi-drug resistant TBAs, PNHIV who have completed the drug-resistant TB treatment. So these are the 4 to 5 points which are contraindication to IPT. And what do we do in IPT worker when to how to evaluate for it? To evaluate for the signs of liver disease, like there is jaundice, tenderness in the right upper quadrant of the abdomen. You need to assess for peripheral neuropathy. You can ask patient that if person is having persistent numbness and burning sensation in feet and hand. Whenever available, a routine LFT, that is ALT, should be performed. But the lack of LFT testing should not delay the initiation of IPT and in a asymptomatic patients. If the patient does not have any abnormality based on the assessment, you can assess for the adherence. Like if there is an adherence issue, if you provide the IPD to the patient, the adherence for IPD will also be less. So when do we in IPD initiation? IPT should be considered for both ART and pre-RT patients if found 4S negative. So 4S negative symptoms are fever, cough, poor weight gain or the weight loss, and history contact with any TB, active TB case. IPT should be initiated if there are no contraindication. In the contraindication, there is active TB disease, patient is having MDR TB, any liver derangement or a hepatic disease, or if a patient is taking any hepatotoxic drugs. IPT must be used in conjunction with the antiretroviral therapy or the ART therapy. The rational approach would be to start IPT after the completion of about 3 months of antiretroviral therapy. IPT drug must be provided on a monthly basis, that is 30 days, to all the eligible patients. And this is the pediatric dosing chart for the IPT. There, it is given in your guidelines also, and you can see from the table. According to the weight band, we have the dose, the number of tablets, and the dose given to the child. And for the adult and adolescent PNHIV, you can give isoniazid and pyridoxine or vitamin B6 per day for 6 months. IPT follow-up. You need to monitor adherence to IPT. As you monitor adherence for ART, you need to monitor the adherence for IPT too. You should always screen the patient for 4S to be done for all PNHIV and CNHIV on IPT during every visit to exclude any active TB. In case a patient becomes 4S positive during the IPT course, he or she should be investigated for TB, and if found positive, IPT should be stopped and appropriate ATT uh, should be initiated. And now the new regime for uh, the TB preventive therapy has come. In this patient who are more than 13 years of age, now we have one HP that is called as the isoniazid and rifampicin that is daily for 28 days. And in this, you don't need to require the drug modification of dolutegravir in 1 HP cases. Patients who are less than 13 years of age, pregnant, and a breastfeeding woman with HIV, and those who are on protease inhibitors like PI, lopinavir, atazanavir, you need to give INH daily for 6 months. And patients who are having contact with drug-resistant tuberculosis, you need to give 4 months daily rifampicin. With the contact of TB patient with isoniazid mono and polyresistant and rifampicin accessibility, and there should be a proper documentation or history for TB among family and members. For the close contacts and a drug resistance of index TB patient should be done. And also, PLHIV who are less than 13 years of age who have successfully completed the treatment of TB disease, you can give the secondary prophylaxis of INH daily for 6 months. And you don't require to give the secondary prophylaxis, the PLHIV who are more than 13 years of age. The TPD as a secondary prophylaxis is not required. The most important is PLHIV who are less than 13 years of age, the pregnant and breastfeeding, the patient who are on protease inhibitor, and those who are less than 13 years of age and have completely successfully completed the treatment for TB, you need to give isoniazid daily for 6 months, according to the weight band. And PLHIV who are 13 years of age and older, you need to give 1 HP, that is isoniazid and rifampicin daily for 28 days. So the IPT provision in specific situation. So in the scenario one, if you see patient previously who has been treated for TB, you give IPT as a secondary prophylaxis. Action to be taken is all CLHIV, PLHIV who had successfully completed treatment for TB disease earlier should receive INH for 6 months or who are having past history of TB. All CLHIV and PLHIV who have just completed or successfully completed treatment for TB should receive INH for additional 6 months. That is for patients who are less than 13 years of age. IPT with ART as a secondary prophylaxis. There can be combined use of IPT and ART is recommended for all CLHIV and PLHIV, regardless of degree of immune suppression. Previous treatment for TB, pregnancy, ART should not be delayed while starting or completing a course of IPT. IPT provision in such specific situation, the scenario third, IPT in children born to microbiologically confirmed TB mothers. If a baby is born to a microbiologically confirmed TB mother, assess the newborn for the active TB. If the non-specific features suggestive of neonatal TB include like fever, low birth weight, hepatosplenomegaly, the child is very irritable, feeding intolerance. If the child has none of the above signs, give IPT for 6 months according to the weight band of the child. And a patient on IPT who develops TB during IPT treatment, this patient develops TB symptoms during IPT or a TPT treatment. We need to evaluate the patient for TB and conduct a drug sensitivity testing. Based on the DST result, appropriate treatment should be provided. If a patient is come out to be TB positive, you need to provide the anti-TB treatment to the patient. And if the patient is found to be having drug resistant TB, you need to refer the patient to the drug resistant TB center. Patient develop TB after the completion of IPT treatment. Treat the TB episode as the RNTCP guidelines and a rifampicin resistant pattern whenever available. If the patient is sensitive to all the drugs, then provide the ATT which we have, the anti-TB treatment, the 4-FDC treatment. If the patient is found to have a drug-resistant TB, refer the patient to the drug-resistant TB center. And in cases we need to require restarting the IPT after interruption. Scenario one is if a patient had taken IPT for less than 1 month in total and discontinued for any reason like toxicity or loss to follow up or pill fatigue, you need to conduct a adherence counseling and address for the reason of discontinuation and ask if asymptomatic, you need to restart the INH therapy. Ensure they have completed a 6 month course. And second scenario is after taking IPT for more than a month, if the patient has discontinued IPT for less than 3 months, you need to again conduct adherence counseling. And if found asymptomatic, you need to restart the INH. But the total duration ensure that they complete a 6 month course within a 9 month period, not beyond that. And if a patient was taking IPT after taking the IPT for more than a month, if the patient discontinued for more than 3 months and above, or had discontinued more than once, so you don't need to reinitiate the IPT. Now, the one more common and opportunistic infection which cause mortality and morbidity in most of the CLHIV and TLHIV cases is cryptococcal meningitis disease, and it is an opportunistic fungal infection that occurs primarily among PLHIV with advanced stage disease and is an important cause of morbidity and mortality. The most common presentation of cryptococcal disease is cryptococcal meningitis or meningoencephalitis, which accounts for more than 15% of all age-related deaths globally. Mortality from cryptococcal meningitis is highest in developing low-income countries, counting about 70 to 80% in low-income versus 30 to 30. So it's a uh, uh, very important opportunistic infection which we need to treat and rule out. So the major reason for high mortality is delay in diagnosis, largely because of limited access to lumbar puncture and rapid diagnostic assay. What are the tests we can use for the diagnosis of cryptococcal infection? There are three types of tests which you can use: the antigen detection, the microscopy, and the culture. For the antigen detection, the sample can be a serum or a CSF. For microscopy and culture, you require CSF sample. The method of testing for the antigen detection is cryptococcal antigen lateral flow assay. For the microscopy, it is a gram stain or India ink. The culture, it is a fungal culture media method of testing that we use. Cryptococcal antigen test is currently not available in programs. So, screening and prevention, how to screen a cryptococcal meningitis and how to prevent the disease. Screening for cryptococcal meningitis followed by a preemptive antifungal therapy among a cryptococcal antigen positive people to prevent the development of invasive cryptococcal disease is recommended under the national program before initiating or reinitiating ART for adults and adolescents living with HIV who have a CD4 count less than 200. So it is a very important point. Patient who have having CD4 count less than 200, you need to screen the patient for a cryptococcal antigen test before initiating or reinitiating the ART. Screening is not recommended for for children less than 10 years, as there is very low incidence of cryptococcal meningitis in this group. Use of serum cryptococcal antigen test and its eligibility criteria. It has been noted that the cryptococcal antigen test, LFA test, is reliable. It is very easy and robust to perform and can be used to diagnose cryptococcal infections in CLHIV or PLHIV having CD4 count less than 200. So any patient, if you found that the CD4 count is less than 200 with symptoms of meningitis, you need to perform the serum cryptococcal antigen testing. If that comes out to be positive and the CSF analysis also come out to be positive for cryptococcal antigen, you treat that patient as a cryptococcal meningitis. And if the second criteria is if the serum cryptococcal antigen test is positive and the CSF analysis is negative, not feasible or possible. If the patient is symptomatic, you treat the patient for cryptococcal meningitis. If you found that the patient is asymptomatic, you give them a preemptive treatment or a presumptive treatment. If the serum cryptococcal antigen testing is negative and the CD4 count is less than 200, if the patient is symptomatic, consider evaluating for other causes. And if asymptomatic, standard care of package, no need to give a preemptive treatment. And if there is CD4 count less than 200 and the serum cryptococcal antigen testing is not feasible, the CSF analysis is also not feasible. And if you found that the patient is symptomatic, you need to consider the patient for TB, cryptococcal meningitis, and bacterial meningitis. You may consider a presumptive treatment or a preemptive treatment for the cryptococcal meningitis or a bacterial meningitis based on the symptoms or the report of the patient. If you found that the patient is symptomatic, fluconazole primary prophylaxis is given if the CD4 count is less than 100. So, in the 17th TRG group meeting, the screening criteria for cryptococcal meningitis among PLHIV should be kept at CD4 less than 200 in the line with the definition of AHD. Till the time cryptococcal antigen test is not available in the program, you can give a fluconazole primary prophylaxis should be given all those cases with the CD4 less than 100. The main important point is as the test is not available routinely available or not available in the narco program. But if a patient is having CD4 count less than 100, we need to give the patient a fluconazole primary prophylaxis. It is important to offer a presumptive or a preemptive treatment if asymptomatic LHIV test positive for cryptococcal antigen test. Everyone who's testing positive for serum or plasma or whole blood cryptococcal antigen during screening should be carefully evaluated for signs and symptoms of meningitis to exclude any active cryptococcal meningitis before you initiate a presumptive treatment. So there are three phases, you can say, the preemptive treatment: the induction phase, the consolidation phase, and the maintenance phase. For induction phase, you give fluconazole 800 mg per day for adults and 12 mg per kg per day for adolescent for 2 weeks. For the consolidation phase, again you give the fluconazole therapy daily for adults and 6 to 12 mg per kg per day for children or adolescent, the for which the maximum dose is 800 mg per day for 8 weeks. For the maintenance phase, fluconazole dose is 200 mg per day for adults, and for children, it is 6 mg per kg per day for children and adolescents until there is evidence or the of the immune reconstitution. Three phases of the preemptive treatment: induction, consolidation, and maintenance. For the induction phase, fluconazole is 800 mg per day for 2 weeks. For the consolidation phase, the dose is same 800 mg per daily for adults for 8 weeks. The maintenance phase, the fluconazole therapy is 200 mg per daily until there is a evidence or a proven immune reconstitution in that child or the adult person. The criteria of discontinuing the fluconazole maintenance treatment take into the consideration of all of the following. Person is adhering to ART and free of cryptococcal disease. The fluconazole maintenance treatment given for at least minimum for 1 year. CD4 count should be more than 100 and there should be suppressed plasma viral load. That is plasma viral load, the HIV viral load should be less than 1000 copies. So if in case the cryptococcal antigen testing is not available, primary prophylaxis may be given to HIV positive patient, though adult and adolescent, in which the CD4 count is less than 100. The recommended dose is fluconazole 100 mg once daily, and the criteria for discontinuing is same for the fluconazole primary prophylaxis. That is, person should be adherent to the ART and should be free of cryptococcal disease. Fluconazole should be given for at least 1 year. The CD4 count should be more than 100 cells, and the viral load of that person should be suppressed, that is less than 1000 copies. And if a person is, if the cryptococcal antigen testing is positive, and the CSF analysis is also positive for cryptococcal antigen testing, we have treatment phases. In this, we have induction again phase, a consolidation phase, and the maintenance phase. The induction phase, the preferred regime is amphotericin B and flucytosine for 1 week, which is followed by fluconazole therapy for 1 week. And alternate therapy can be 2 weeks of fluconazole therapy and flucytosine, and the second alternate can be 2 weeks of amphotericin and fluconazole therapy. So for the induction phase, the preferred regime is amphotericin B. For the consolidation phase, fluconazole therapy is given. The dose is 400 to 800 mg daily for adults, which is given for 8 weeks. The maintenance of the secondary prophylaxis, the fluconazole dosing is 200 mg per daily for adults. And when to discontinue the fluconazole maintenance treatment, it is recommended that after successful treatment of cryptococcal disease, meningeal and non-meningeal, the criteria for discontinuing fluconazole maintenance therapy should be taken into consideration all of the following. The person should be adherent to ART, free of cryptococcal disease. There should be fluconazole maintenance therapy or the fluconazole therapy treatment should be given for at least 1 year. The CD4 count should be more than 100, and the plasma viral load of that patient should be less than 1000 or suppressed. And important point to be noted is if a medication for the treatment of cryptococcal meningitis, so this if somebody required amphotericin B, flucytosine, and fluconazole, will be made available from the SACS or the institution. The ART medical officer or the senior medical officer needs to request the SACS or the institution superintendent for the treatment of these drugs. So, what are the vaccination that can be given in these children? Vaccines are extremely effective primary prevention of tool for common life-threatening childhood infections in children. Vaccines that protect against the 11 diseases are included in the national immunization schedule by the government of India for the routine use in children and adolescents in India. Apart from these vaccines, many optional vaccines are also to be considered on case-to-case basis. Immunization and the vitamin A supplementation. All the HIV exposed infant, all the HIV exposed babies, like all other infants, should be given BCG at birth. If BCG has not been given in the birth, or it should not be given in symptomatic HIV infected older infants and children. Live vaccine can be avoided or deferred in all severely immunocompromised infants, those who are having CD4 percentage less than 15 or in the range of severe immune deficiency for older children. Vitamin A supplementation should be as per the national immunization schedule. The rotavirus vaccine is recommended for the use in HIV exposed infants due to the vulnerability to diarrhea. The JE vaccine is inactive and found to be safe for use in children with HIV. Check for seroconversion and give booster as required, especially for hepatitis A and hepatitis B. Additional optional vaccines should be given depending on case-to-case basis. And this is a national immunization schedule. All we can say at birth, we give BCG, OPV zero dose, and hepatitis B birth dose. At 6 weeks or 1.5 months, we give OPV, rotavirus vaccine, FIP, and pentavalent one. For at around 10 weeks, we give OPV2, the rotavirus 2, pentavalent 2. And at the 14 weeks, we give OPV3, rotavirus 3, FIP2 or IP2, and pentavalent third dose. At 9 months of age, we give MCV1, measles vaccine, JE vaccine if in a selected endemic districts, and vitamin A supplementation. And vitamin A supplementation should be given every 6 months till 5 years of age. At 15 months, we give measles vaccine, and in the 16 to 24 months, we give DPT's first booster, UPV booster, JE2, and vitamin A. At 5 to 6 years of age, we give the second booster dose of DPT. 10 years of age and 16 years of age, we give TT or DTD, you can say. And in the pregnant mother, you give the TT1 and TT2. So the key points from today's topic is all the HIV infected children, that CLHIV, are susceptible to many opportunistic infections. And the treatment and prevention of OIs or the opportunistic infection is important component of the comprehensive care of any CLHIV. Chemoprophylaxis, as we suggested, are primary and the secondary prophylaxis. Cotrimazole preventive therapy or the Sepran therapy, as we have read from all the today's session. TB preventive therapy, TPT, the eligibility criteria, the contraindication, the revised TPT guidelines, and TPT or the IPT therapy in specific scenarios. Primary and secondary prophylaxis for cryptococcosis, and vaccine preventable disease and the national immunization schedule. Um, any questions regarding today's session?
Yeah, thank you, ma'am. Ma'am, there's one question in the chat box. What will be the
Yeah.
dose of LVF?
What is the dose for?
LVF.
LVF, levofloxacin.
Yeah, Dr. Atul sir, can you unmute and ask your question?
Yeah.
And sir, can we give mic access to everyone? Any more questions? Participants can now unmute or they can put their questions in the chat box. Dr. Atul sir, Atul Anand sir, can you please unmute and ask the question? Any more questions from the participants? Yeah, Dr. Harshita ma'am, can you please answer the question? What will be the
L
dose of, yeah.
LVF is levothyroxine or any Lasix? I wanted to ask Dr. Atulan. So,
I'll just check if sir is there in the session. Yeah, he's there. Sir, you are on mute. Can you please unmute? Ma'am, we are unable to reach him.
because it is not the if he can give me the full form of LVF, what question is he
Okay.
asking?
What we'll do is after the session, we'll try to contact him and then we'll get his question to you. Is that okay?
Yeah, it is perfectly okay.
Right? Okay. Okay, ma'am.
Yeah,
Any more questions?
yeah.
We'll wait for another 2 minutes.
Yes.
Ma'am, I don't think there are any questions. Thank you so much for facilitating this session.
Okay. Thank you. Thank you so much.
Thank you, ma'am. Thank you to all the
Thank
participants for patient listening. We'll conclude the session now.